Right, so today I want to talk to us and I take us on a journey, and I want us to engage. I'm not going to do all the talking. We are going to do this together. I'm not a data scientist. I am not that educated. I've not been to university. I'm none of those things. So I want you to imagine if you could have an opportunity to go back in time and choose your parents. And then you had an opportunity to choose where you would be born, and you would have an opportunity to choose how you would look like, to choose where you would live, to choose how your parents would look like, to choose how your siblings would look like. Can you imagine those things that you would want to be in that pot? Can you imagine how you would like that life to look like? And then on the other hand, can you imagine those things that you wouldn't want? And then take a moment to imagine why you wouldn't want them. So it is those exact things that determine what you like, how you are born, where you are born, and then what you do in the life that you live, and maybe where you choose to live. All those things that you've imagined. The amazing thing is we don't have a choice over those things. I am Fungai Ndemera, born in Zimbabwe, in a little town called Rimuka Kadoma. And that's in Africa, from a place where you would never imagine people like me standing in front of you today would come out. I am Black, I'm female, and I'm African. Those things that I've just described, I did not choose them. I found myself here in that little town with my parents being a sibling of many children, and my father doting children everywhere, having kids with so many women. I didn't choose that, but there I was doted. So many years, I'm 46 years today, this year. 46 years later, I live in England. And I find myself today speaking to you at this science park. But guess what? The action of coming here today was a choice. I chose to come here. And I chose to come and discuss this topic, which I'm going to talk to you about. So, digital transformation, addressing health inequalities in healthcare. I am on a mission to make healthcare equitably accessible for everyone. The things that I've just asked you to imagine are what we call social determinants. You don't choose those things. Yet those things determine the quality of life and your health, whether you like it or not. They impact you from when you are in a mother's womb, the stresses that my mom was experiencing when I was in a home. Now I still am being affected by those things. They may affect me psychologically, they may affect my emotions, they may affect my mental health. Those are social determinants. And they constitute health equity. We don't control those things. But the things that we can control, that are unjust, that are unfair, that are systemic, that are caused by us as human beings, by the choices we make and the systems we put in place, are called health inequalities. Those are the ones I am interested in us discussing, engaging, and thinking about them very closely in our everyday life. Because these things, we as human beings, if we make a decision to stop choosing them, and change the path, it will improve health outcomes for the underserved, the underprivileged, and the people who are in the populations who don't choose to be born disabled, who don't choose to be born underprivileged, who don't choose to belong to a poor family, who don't choose to live in poor areas. They don't choose. And so we have got a role to play. So I'm an entrepreneur, I'm an investor, I am a technology person now in health tech. I am a nurse by profession. I haven't done bedside nursing for 20 years. I'm a founder of CheckUp Health, and we are on a mission to make healthcare equitably accessible to everyone. So in England, we need urgent action. And by the way, this report, I'm not the one who wrote it, by the way. Those living in most deprived areas, they spend over 1/4 of their lives in poor health, compared to less than a sixth for those in the least deprived areas. And that's the King's Fund report. And these people, by the way, are saying they don't choose to be living in those areas, but their health is affected because they live in those areas. So I have come up with a model that I think that if we look at using that approach, as we go digital, we can narrow the gap and we can manage that. So I've come together, I've thought about it, and I keep improving this thing because this is where I spend my time. This has become my life mission, basically. So as we go digital, there is a lot going on. Everybody is doing their best, and I want to acknowledge the power that was brought and given to us by the event called COVID. I have been trying to create technology and introduce digital healthcare since 2009. 2004, my father and my father-in-law died a week apart from undiagnosed diabetes, and they were non-hypertensive patients. And from there, I was very angry. I was very upset. But what I did was I took that energy and pursued the why. I wanted to understand why these things are happening. And so if I tell you that since 2009 to 2020, I had been trying to have a conversation with the NHS about introducing my project to the NHS, and I was facing a brick wall. And guess what? COVID threw us right into it. April, I put an application to Innovate UK. We could see the numbers and the statistics. Black people were dying the most from COVID-19 compared to the white counterparts. And I thought, and my team, what can we do to be involved? And we simply approached Innovate UK. We put our application together and we said that we already have a clinical platform. We would like to offer remote health consultations to the underserved and to this demographic. And thankfully, the application was successful. And so we ran a pilot project to focus in on giving access to the people who were not able to go to have an appointment with a GP for one reason or the other. We were monitoring their high blood pressure. We were monitoring their diabetes. And any parameters that were outside the acceptable parameters, we were giving a clinician to speak to them or have a video or an online consultation with them. And so if I tell you that the acceleration that has happened between 2020 and today, the technology that I'm talking about, CheckUp Health, is now one of the 8 innovations that has been approved by the Tech Innovation Framework to support primary care. And that has taken 2 years. Before COVID, it was taking me that long. So I think as human beings, there is something we need to do to change the way we think. Does it have to take people to die for us to realize that we have something that we need to do right now that is urgent? And that something is to address health inequalities and ensure that as we go digital, the excluded people or the underserved or the underprivileged also have an equal opportunity to access, but also equity. Equitable access means that if I'm giving these 2 gentlemen here in front a phone to use, I must consider whether that phone is going to be appropriate to meet their needs for them to be able to make a phone call to a GP. Right now, as we speak, the NHS app, which is the national app that is supposed to be used for patients to access healthcare services digital, is in one language. That's one good example. In the UK, how many other languages do we have that form part of the population? At CheckUp Health, we've made an effort to make it our agenda that by end of 2023, the platform is going to be in 20 languages. To date, it's in 6 languages. Yet the National Health Service platform is in one language. And so how are we saying we are bringing everyone and everything is going to be equal? How do we improve access if we are not thinking about simple things like that? That's a question I'm posing to you. I said you guys are doing the thinking. So, inequitable access to user-centered technology designed for every patient. And I'm just going to rush through my slide. So to harness digital tools for the health service to reach and engage with the hard-to-reach vulnerable people, access to medical expertise, AI tools can be extended to reach skills of the existing workforce. Trusted health information. One of our findings when we did the pilot was very simple. People from ethnic minorities, they simply don't trust the center. They simply don't trust the system. Is it a cultural thing? Yes, I would say it is. It took me till 3/4 into COVID for me to convince my mom for her to have her COVID jab. These thoughts and these mind frames are beliefs framed from personal experiences. If we look in history, when the syphilis vaccine was done, or when the syphilis drug was done, we know that in America, it was given to black males without their permission. And so they end up dying and destroying people. So history shapes how people think today. So for me to go and convince my mom to say, go and have the COVID vaccine, she's like, no. But we can't blame her. We need to understand why she thinks the way she thinks. That's one good example. So our findings were mistrust. So effort needs to be given to accommodate everyone. And then inequitable support to access, monitoring and preventative tools and interventions, and interoperability. I must say right now, as I speak to you, I must commend NHS Digital though, because with the Tech Innovation Framework, they have come forward and say they are pushing for interoperability for primary healthcare services to use integrated systems, I think from the previous speaker that was speaking, because integrated systems make it easy for information sharing, make it easy for access for the patients, and make it easy for access for the professionals. So I must commend them for that. And I must also commend them because the biggest sticking point was the support of the resources and the funding. And the Tech Innovation Framework is coming with funding for early adopters of those products or primary care services, or early adopters of GP practices who are coming to say, we want to try technologies and we want to put things right. And we are on a journey to support primary care health services do that because our platform is homegrown. We create it from scratch. We don't depend on anyone. We don't need to ask for permission to do anything. We are very quick and agile in our approach and we implement. So we are currently running pilots with 2 GP practices, helping them manage their overflow and also integrating in that, weaving within our system accessibility, equality, equity, to make sure that nobody is left behind. So thank you for listening.